I presented that abstract on Saturday, and just to give you a little background, so you probably know that hemophilia is an X-linked recessive bleeding disorder, which has always been considered as affecting mostly male patients. But studies in the recent years have shown that female carriers of the disease of the affected X chromosome can also be affected by hemophilia. So it is important to screen carriers in families with hemophilia. And with our study, we wanted to explore that a little bit further. At our center, hemophilia carrier screening has been part of the clinical routine since genetic testing became widely available. But with the Prokarriers 1 study, we wanted to be even more systematic and proactive about it. So what we did was to update our hemophilia patients' pedigrees systematically when they were seen at the clinic or also during telephone interviews. And then when we provided the patients with invitation letters to our study, which we asked them to forward to the unscreened females in their families. And then the women who got back to us and accepted the invitation were seen at the clinic, where we assessed their bleeding phenotype, factor levels, and also with their consent did genetic testing for hemophilia. And we merged these data then with retrospective data which we obtained through the electronic medical records, because we also wanted to compare carriers of hemophilia A and B in terms of bleeding symptoms, coagulation factor levels, and circumstances of diagnosis. And what we found was that coagulation factor levels were significantly lower in hemophilia carriers than non-carriers, but they did not significantly differ between carriers of hemophilia A or carriers of hemophilia B. The females who had a coagulation factor deficiency mostly had mild hemophilia, but we also have rare cases of women with severe hemophilia and women with mild hemophilia but a relatively severe bleeding phenotype. The age of diagnosis was at about 30 years in both hemophilia A and B carriers. And what I also should mention is that in the families of 236 hemophilia index patients, 287 male index patients and 7 female index patients, we found 900 females in total. So this is quite a big population. And we really were able to get a precise inventory of our patient and carrier population. We know that at least 454 females in these families are carriers of hemophilia and 118 are non-carriers. On the other hand, there are still 328 potential carriers who still need screening. But you must also know that in these 328 females, you have some that are very young or very old, or also who live abroad, so they are more difficult to reach out to. Regarding treatment for bleeding, we saw that hemophilia B carriers had to rely more on coagulation factor concentrates, but this can be explained by the fact that we don't have DDAVP as an option in those patients. And to summarize, we think that proactive and systematic hemophilia carrier screening should be part of the clinical routine and of every comprehensive hemophilia clinic. And furthermore, diagnosis and care of hemophilia should be accessible to all hemophilia patients or potentially affected persons, regardless of their gender. And this is also not just something that we believe in, it has also been emphasized in the European Principles of Care for Women and Girls with Hemophilia.